So first we'll start about the biochemistry, about the plasma proteins. So what are plasma proteins and where they are made? Basically, these are proteins found in blood serum and represent approximately 7% of total blood volume. 7% of total blood volume and found in blood serum. They are made in the liver. We already know plasma proteins are formed in the liver except for the gamma globulins, immunoglobulins that are secreted by the plasma cells. So these are secreted by the B lymphocytes, the gamma globulins. Immunoglobulins represent approximately 30% of all plasma proteins. Approximately 30% of all plasma proteins are immunoglobulins, which are secreted by the B lymphocyte. So now what are the function of plasma proteins? Albumin represents a 60% of all plasma proteins. It is a transporter binding calcium, and it is also involved in Starling's laws of the capillaries, maintaining the plasma oncotic pressure. Function of plasma proteins include complement cascade components, enzymes and enzyme inhibitors, clotting cascade, example factor 1 fibrinogen, in the gene expression regulatory proteins, immune system like the gamma globulins, immunoglobulins, as Starling's law of capillaries to maintain the plasma oncotic pressure, we have already discussed, as transporter proteins. Okay, complement cascade, clotting cascade, gene expression, enzymes, immune system, Starling's law of capillaries, transporter proteins. Okay, now we'll see about the calcium. What is the normal range for serum calcium and what is corrected calcium? So normal range is 2.2 to 2.6 millimole per liter. It is important. Approximately 50% of the calcium is bound to albumin. 50% is bound to albumin. Unbound calcium is biologically active, so it is important to factor the level of serum albumin into any serum calcium measurement. Okay, so unbound is the biologically active form. Adjusting for this obtains the corrected calcium. So a normal serum albumin figure of 40 gram per liter is used in the following equation to calculate the corrected calcium as follows. So it is very important. Corrected calcium we can calculate is equal to total serum calcium plus 0.02, and then we have to subtract normal serum albumin minus the patient's serum albumin. Now the corrected calcium and total serum calcium should be in millimole per liter. Normal serum albumin and patient serum albumin should be in gram per liter. Okay, so it is important. The corrected calcium is equal to total serum calcium that is given plus 0.02, and then the product of the subtraction of normal serum albumin minus patient serum albumin. If a patient, now the scenario, if the patient has a serum calcium of 2.6 millimole per liter and albumin of 35 gram per liter, what is their corrected calcium? So again, we'll apply that formula, 2.6 plus 0.02, then the normal albumin minus the patient serum albumin. So normally is 40 minus the patient here given value is 35. Okay. So now we can see the total serum calcium plus, so serum calcium was already given 2.6 plus 0.02, 40 minus 35 it's 5. So the corrected calcium would be 2.7 millimole per liter. Now we'll see about the hyperuricemia. What is urate and what is the normal reference range? Urate or uric acid is a product of purine metabolism. That is adenine and guanine. These are purine. Normal reference range is 3.5 to 7. Uric acid, for uric acid is 3.5 to 7. Urate less than 8. It is a trick to remember the serum value. What are the causes of hyperuricemia? So these may be primary or secondary causes. Primary causes, idiopathic, inborn errors of metabolism. Secondary causes can be alcohol in alcoholic diuretics or protein-rich foods. What are the consequences of hyperuricemia? So that can be classified in acute or chronic consequences. So acute can be gout that present classical picture of a hot, painful and swollen metatarsophalangeal joint, although other joints may be affected, example the ankle, knee, hand, wrist and spine. Along with that, low grade fever, painful skin tophi. In the chronic hyperuricemia features, that will be destructive joint disease, polyarthritis, urate renal calculi, renal failure, and skin tophi ulceration and chalky discharge. Okay, so ultimately, due to prolonged inflammation, that will cause the destructive joint disease, polyarthritis, renal dysfunction, urate renal calculi, and renal failure, and the skin ulceration, tophi ulceration, and chalky discharge. Now, what are the pathological features of the gout? 10% of the patients with hyperuricemia develop gout. There is rapid uric acid crystal deposition. Rapid uric acid crystal deposition in the cartilage, synovium, and tendons of the affected joint. Larger deposits known as tophi. So the larger deposits are known as tophi, may also ulcerate through skin, like we have discussed skin tophi ulceration. Joint aspiration reveals, very important, negatively birefringent crystals which appear yellow under polarized light. So these all are very important pathological features of gout. So the aspiration will reveal the negatively birefringent crystals which appears yellow under polarized light. So now about the hepatic function and jaundice. What are the functions of the liver? So very important, bile production, bilirubin conjugation, clotting factor synthesis, drug metabolism, glycogen storage, plasma protein synthesis, production of heat, reticuloendothelial system. So bile production and bilirubin conjugation, you can remember both of them combined. Then the clotting factor synthesis, drug metabolism and glycogen storage, plasma protein synthesis and production of heat, clotting factor synthesis, plasma protein synthesis, production of heat and reticuloendothelial system. Okay, now we'll see about what is bilirubin and what is the normal reference rate. 90% of the RBC are broken down in the reticuloendothelial system, RES, and the remainder are hemolyzed within the circulation. Globin and heme are breakdown products of these processes. Bilirubin is a bile pigment. It is produced by the breakdown of heme to biliverdin, followed by conversion in macrophages to bilirubin. So it is basically produced by the breakdown of the heme to biliverdin and then conversion in macrophages to bilirubin. These occurs within the RES system, and the resulting bilirubin is unconjugated and insoluble at this stage. The normal range is 3 to 17 micromole per liter. So here we'll see about it is a schematic representation of the jaundice cycle. So examiner can also ask, can you draw the bilirubin metabolism cycle, explaining each step as you go along. So in the reticuloendothelial system, RBC, as we have discussed, will release the heme that is converted into bilirubin. Then unconjugated bilirubin enters the bloodstream bound to albumin. Then it is uptake by the liver hepatocytes, where it is conjugated. In the liver, conjugation happens with glucuronic acid and UGT. Then it is released, conjugated bilirubin diglucuronide excreted with bile in micelles into small intestine. In the small intestine, deconjugated to urobilinogen by the large intestine bacteria. Then in the large intestine, it can be absorbed, excreted in urine as urobilin, reduction in excretion in feces as stercobilinogen. Okay, heme, bilirubin conversion, after conversion bilirubin, and then unconjugated will bound to albumin, and then it is uptake by the liver hepatocytes, then it will be released in the form of conjugated bilirubin, then again deconjugated as urobilinogen by large intestine bacteria, then it can be absorbed and excreted in urine as urobilin, and it can be excreted in